Good afternoon, everybody, and good morning to those of you on the West Coast. My name is Bobby Georgiou. I'm a Benefits Realization Leader with Canada Health Infoway, and I'd like to welcome you for attending this webinar, and to thank you for taking the time to attend. We've been working at this for the past 6 months or so, and we're very excited to finally share the results with all of you. On the next slide, just have a couple of notes. One, that this session will be recorded, and it will be posted on our website for future access, or for those who were not able to attend today. As Teresa mentioned, we would love to take calls, but there are over 200 people on the line, so we will need to use the Q&A feature. So please type in your questions, and if we have some time at the end, we would love to get to at least some of those questions. And on the next slide is just a reminder of how to use the Q&A functionality. But on that note, I would like to pass it over to Kathy Winter and the rest of the Ernst Young team to take you through the full presentation.
Thanks very much, Bobby, and good afternoon, everyone. It's a pleasure to be here. My name is Kathy Winter, as Bobby said, and I'm in Toronto, and I'll be sharing the presentation today with my colleague, Ronan Seagrave, in Vancouver. Before we start, I'd like to also thank Canada Health Infoway for their guidance and support through this project, as well as the members of the advisory panels who offered great insight to our findings and recommendations as part of this report. So our agenda today is to talk a little bit about our approach and methodology for this piece of work, how we undertook the background and current state, some of the key findings from the project, and what that means for moving forward in terms of supporting the broader implementation of remote patient monitoring in the country. So the purpose of this project was to inform the potential for remote patient monitoring implementation across Canada. Infoway has insight into a number of projects that are underway across the country, and there certainly is an interest, given some findings in Canada as well as other countries, in terms of the significant benefit to clients using and accessing remote patient monitoring, as well as some quality insights coming from clinicians around some of the benefits that clients and clinicians are realizing as a result of using remote patient monitoring. They were interested in understanding what could be done to actually promote and develop the adoption of remote patient monitoring. And to support that work, we undertook an academic and grade literature review of results of RPM projects in Canada and internationally. We synthesized that and supported the identification of some projects that were showing great promise to have a more in-depth analysis. We undertook some key informant interviews, and then we did some in-depth case studies to look at potential return on investment analysis or benefit to clients of mature programs, and then provider and consumer surveys to gather additional program information. Canadian RPM programs were assessed against a series of constructed hypotheses to understand access, quality, and productivity benefits to be realized. So each of those case studies were evaluated against those criteria. An assessment of scalability was made for programs able to demonstrate benefit, and the programs that were unable to demonstrate benefit at this time, mostly because they were smaller or in the early stages of implementation, but held promise, were also featured as emerging solutions. Infoway's expert advisory panel was consulted throughout each phase of the project. This is a multi-phase approach, as you see on the next slide. We looked at potential programs driven from the literature review and key informant interviews. We selected the top 4 to 5 programs as well as some emerging solutions, and then we filtered those programs through a series of decision criteria around evaluation readiness, ability to be evaluated, their ability to demonstrate benefits, and then created a draft report for Infoway, which introduced the concepts as well as the critical success factors for adoption of remote patient monitoring. Background and current state. This diagram on page 11 is a schematic of what remote patient monitoring is, and certainly one of the first steps as a group was to come to an understanding about a common definition understanding for the purposes of the project around remote patient monitoring. For the purposes of this project, we conceptualized remote patient monitoring as actually a spectrum of programs based on the complexity of the technology used and the acuity of the patients or clients targeted. And we divided the spectrum into 4 streams representing programs of increasing complexity. So we looked at those, or we identified those RPM streams that were more enabling information, such as websites, those that were self-monitoring, so interactive or educational programs, those that were assisted monitoring, likely by a third party, and then environmental monitoring, which is likely in residence or family homes with motion detectors and cameras and such to monitor activities over a period of time. The diagram further goes on to look at different levels of engagement of providers, potential cost, and then to look at the complexity of residents, clients, patients in different care settings. So this diagram is intended to show essentially that this is a very complex question if you want to look at remote patient monitoring, addressing client needs over a variety of settings, engaging a variety of stakeholders using different technologies and different costs. We accessed the Kaiser Permanente triangle, some of the concepts from this concept to come up with a risk stratification framework. This was a process that enabled us to identify those patients or those clients who would most benefit from involvement in remote patient monitoring and have the ability to demonstrate results or benefits or outcomes, positive outcomes as a result of using remote patient monitoring. So on the left, you'll see the low risk of hospitalization, medium, and high risk, and then the patient profile that best suited those different risk profiles, and then the RPM solution that might be most amenable to having benefit to that client population. Just pause for a sec to give you a chance to look at that. Okay. The next piece of work that we undertook was to combine the risk stratification profile, the literature already reviewed by Canada Health Infoway, and start to look at what the activity was across Canada and internationally. And this was to in part inform which cases we wanted to go in depth around, and also what lessons could be learned from experiences across Canada and internationally. In Canada, we discovered that almost 5,000 Canadians are currently enrolled in 23 different RPM programs. And again, RPM programs as identified by the definition of RPM used for this, this project. We recognize that there are a number of applications that people are using on their communication machines, which are around monitoring symptoms or used for education, and we did not include those applications or that volume of Canadians who might be accessing those applications as part of this population. The programs are aimed at improving the management of chronic conditions while reducing avoidable patient admissions and emergent department visits. The majority of activity around remote patient monitoring, as we defined it for this project, is occurring in British Columbia, Ontario, and Quebec. The interest and engagement in remote patient monitoring is growing, with an annual growth rate of 15 to 20% in large RPM programs across Canada. And this number was developed based on the number of new registrants or new enrollees in these RPM programs. The majority of programs are designed for sub- and or post-acute patients with congestive heart failure, chronic obstructive pulmonary disease, or diabetes. And in the literature, we found that the benefits associated with using remote patient monitoring showed the greatest promise of having positive outcome or benefit for those patient groups. Many smaller scale programs initiated as pilot projects have been adopted by multiple regional planning bodies and health service providers. So we're seeing some uptake of programs that are going beyond a one institution or one organization format to being more widely distributed and accessed across regions. Internationally, we reviewed 12 programs. Programs such as the Whole System Demonstrator Program in the United Kingdom, the National Program for Telemedicine and Home Monitoring in Denmark. Both have shown considerable reduction in hospitalizations and emergency department visits through the redesign of models of care and the integration of evidence-based care pathways. And certainly one of the findings from the literature review and interviews showed the greatest, or one of the greatest benefits for those with using remote patient monitoring are for patients and physicians who are looking at a redesign of the model of care to integrate remote patient monitoring. So it's less about the technology itself, but more about how the technology can better enable positive or constructive models of care. Programs have been able to consistently demonstrate benefits through ongoing engagement and collaboration with providers and by engaging clinicians and patients through the recruitment and design and implementation of the program. So these have been, again, very important findings that when you are engaging providers with clinicians and patients and families, again, the benefits are outweighing those that are single use or just no intervention or support from clinicians. The evidence for cost effectiveness has been mixed, however, based on generally the lack of good comparable data over multiple years using consistent ways of demonstrating cost effectiveness and measures of acuity. Also, in many cases, non-standardized benefits were measured and different ways of recruiting and engaging patients were used. So to some extent, the comparability of some of these studies was limited. However, we did control for that in some of our analysis. So after we reviewed the literature and interviews, we then came up with what we called benefit hypotheses. So these were considered the assumptions or the hypotheses that we felt would be realized through the continuing work and the in-depth analysis in the case studies. So using the Canada Health Infoway benefits framework, we looked at quality, access, and productivity, and hypothesized that the engagement of patients in remote patient monitoring programs with using new models of care would increase patient satisfaction, would increase patient compliance, and quality of life, and promote integrated care. The strength of the evidence was greatest for increasing patient satisfaction, compliance, and quality of life, less so for promoting integrated care. In terms of access, our hypothesis was that it would reduce caregiver burden, it would increase access to specialists, and increase dissemination of health data. However, we found the strength of the evidence based on the literature and interviews was greatest for reducing caregiver burden. In terms of productivity, decreasing emergency department visits and hospitalizations, a very strong body of evidence to support this from the literature. Decreasing per diem client health costs, as well as reducing per client care time from providers. Certainly the strength of evidence was around the ED visit reduction and also for the per client health cost, but less so for the per client care time. We're now going to share some of the key findings from the report, and I'm going to now turn over the presentation to Ronan.
Thanks very much, Kathy, and good morning or good afternoon to you, depending where you are in Canada. I'm Ronan Seagrave from Ernst Young, and one of Kathy's colleagues who worked on this very exciting project for Canada Health Infoway. I just want to take you through our findings, but first of all, just to give you a little bit more information on the selection process. As Kathy has demonstrated, there are a number of different RPM projects happening across Canada, and we needed to select 4 or 5 case studies to do an in-depth evaluation. And in order to do that, we developed a set of selection criteria which looked at the alignment to CHI's strategic goals, when they started, and what's the length of the duration or the maturity of the RPM project. Does the RPM project focus on technology that is scalable? And is it focusing on the key issues for the health system in Canada, focusing on chronic conditions and preventative health? We also had to look at, because of the nature of our evaluation, at some very practical considerations. And even where case studies may have met the selection criteria, there were clearly these other considerations we needed to look at. One, that there was the availability of data in terms of cost, benefits, etc., of sufficient quality and depth that we could actually analyze. The data was reasonably reliable in terms of how it had been collated and obtained, and that we had a reasonable geographic spread. In other words, not all projects skewed to one particular province or location in Canada. And again, we looked at confirming the criteria and the considerations against both the literature review findings and the interview findings for consistency. And as we were going through that process, we recognized that by just having a rigid bar on this, we could miss out focusing on some emerging solutions, particularly aligned to the rapid changes in technology in this field. And these were, as Kathy mentioned, these smaller scale RPM programs utilizing very innovative technologies, web, smartphone, text messaging, etc. And we didn't want to exclude that from a consideration. This study needs to be forward-looking as well as retrospective. So we devised a process which I'll talk about, just to feature some emerging solutions in our report that are interesting, but where we were not able to do the depth of the evaluation in relation to the case studies. I'll just take you through a description of the 4 case studies that came out of that evaluation process. The first one, and I suspect participants are familiar with some or all of these, depending on where you're from and your area of interest. The first one is the Ontario Telehome Care Expansion Program. And again, this is focusing on providing monitoring and coaching for patients with chronic conditions. It promotes self-management and engaging patients in the delivery of their care plans. It's focusing on avoiding unnecessary hospitalization and ED visits, and it's very much designed to be integrated into clinical pathways and models of care. It's funded by the Ministry of Health and Long-Term Care in Ontario and is very much aligned with chronic disease and prevention management programs. The second one is the UOHI Regional Home Monitoring Program, and again focusing on chronic diseases and promoting self-management. The third one is the Breathe Well at Home program based in BC, and this is particularly focused on helping patients manage their COPD, chronic obstructive pulmonary disease, and managing their symptoms as they're discharged home from hospital, or if they have issues around managing their condition at home. And clinicians on the line who are familiar with COPD will be well aware of trying to avoid unnecessary exacerbations of the condition that can result in ED attendances and avoidable hospitalizations. And again, it's connected to through the monitoring through a range of clinical support by a nurse and respiratory therapist, and then working with the patient to provide and support an effective care plan linked to therapy services, rehab, etc. So this is all designed to maintain the patient's care in a home environment and avoid any unnecessary acute activity. And finally, we have the JRHC Telehome Care Program based in Quebec. Again, it's a telemonitoring solution designed for patients with chronic conditions such as coronary heart failure, COPD again, and type 2 diabetes. Again, this involves supporting the patient, documenting and monitoring their condition through submitting various sort of health parameters and data, so for example, their blood pressure, their weight, and using quite an attractive and interactive touchscreen device with a modem that allows the electronic submission of the data, which can then be monitored by nursing case managers, who again can pick up on any variation in terms of that monitoring data that might require an intervention, again to support care at home and avoid any unnecessary acute activity. So we had a process whereby we interviewed in depth representatives from each of these programs. We had a process of obtaining and collecting the data. And again, that was linked and aligned to the benefit hypothesis that Kathy took you through just a bit earlier. And again, I'll just go through some of the findings against each of the three criteria, which links to CHI's overall benefits framework. Looking at the first area of quality and appropriateness, effectiveness, and looking at evidence around increasing patient satisfaction and compliance, certainly found that in terms of the phase 1 of the Ontario Telehome Care Expansion Program, did show some positive impacts on quality of life and supporting patients to self-manage their condition. Breathe Well and JRHC did include metrics around patient satisfaction, around the use of technology, but not with satisfaction or confidence in managing their condition. Improving patient compliance was an objective in the JRHC study. However, we didn't have really sufficient data to use for the evaluation. And Breathe Well utilized a PAM tool to determine improvement in self-management, and that showed some slight improvement in scores to post-study enrollment. I'll talk about this a bit later on, but you're probably already seeing a theme here in terms of some issues around limitation in data and some variation in terms of consistency around how these sub-areas of benefits were measured and evaluated. I looked at sort of health outcomes and whether RPM is contributing to sort of improvement in physiological health outcomes. There was some very slight quantification of this improvement throughout the studies. Breathe Well again used quite an innovative tool in terms of monitoring changes to quality of life and showed some slight improvement, but the outcome here was that there was very little measurement or quantification in this area. And I'll come on to this. This is quite important in terms of clinicians buying into and seeing the value of RPM solutions. Then also looked at access in terms of increased access to health services compared to traditional forms of care, and all of the case studies identified the ability to increase the number of patients monitored and managed by deploying the solutions. However, it wasn't really compared and quantified to current state, so conclusions there are inconclusive. And in terms of what everybody and our expert panel recognized as really important around measuring the potential to decrease caregiver and patient burden and wider, indeed, benefits to the economy, while everyone recognized this was important, none of the studies had evidence to assess that metric, other than to sort of anecdotally say it probably does have an impact, a positive impact. The area where, not surprisingly, we had the most data was around health system efficiency and sustainability. And this is in terms of the impact on the health system utilization, and particularly ED visits and hospitalization. And there was some quite compelling evidence across each of the case studies demonstrating a decrease in health system utilization, again focusing on reductions in avoidable ED visits and hospitalizations. And JRHC also calculated the reduction in necessary nursing home visits, again, visits for monitoring that could be avoided through the use of the technology. So really a very mixed picture emerging. Again, some of our observations from this analysis and this work, we had to make an assumption that the small program evaluation cohort is broadly representative of the client base of each RPM program. And given that criteria, the initiatives and the case studies catered really to the medium to high risk tier of patients, going back to looking at the Kaiser Triangle and our risk stratification framework. And that's not surprising if the focus is around health system utilization, sustainability, and savings. You would be, in terms of trying to capture maximum in-year benefits, focusing on those patient cohorts. Each case study did demonstrate the ability to serve patients well over its break-even point, and without getting into the technicality of the mathematics, the ranges were between 16 to 52% of current maximum capacity. However, as stated, the economic benefits are very heavily skewed towards the system factors, as those were the areas that were systematically measured and quantified across all of the case studies. So when you look at, aligning that with the, improvement in quality of life and physiological improvement and utilization of primary healthcare resources, they were inconsistently measured and analyzed across each of the case studies. So there is that obvious skewing. We found a considerable variation between performance management variables, both what is being measured and how it is being measured across each of the RPM programs. And we'll talk about this a bit later, but this, of course, is really, really important when we look at scaling up and we look at convincing provincial payers and others to invest in this technology. So, I'll talk about this a bit more, but in order to really understand comparable benefits, we need to have much more consistent and standardized processes around capturing baseline, understanding the actual cost of delivery, and understanding the system savings. So there needs to be a considerable degree of more work in that area. And the sustainability needs to be further studied and understood. So the majority of the case studies didn't account for things like seasonal variability, winter pressures, for example, when usually increased demand on the health system. And that really related to variation in terms of the length of the study period for each of the case studies. Interestingly enough, though, UOHI evaluation study did show that reductions in utilization started to decline with increased duration post-implementation. And I'll just talk a bit about the emerging solutions, and I say the interesting issue around some of these solutions is that they are utilizing developments in technology that we're all very familiar with, text messaging, the use of mobile smartphones and tablets, as well as interactive websites. So we looked at, again, using the framework discussed earlier, we looked at 4 of these very interesting emerging solutions. One is WellTel in BC, which is focusing on HIV, TB, and asthma management. This is very interesting, actually. When you read the report, this actually started in Africa, Kenya, I think, where you can sort of understand why there's a great interest in that part of the world around utilizing text messaging. But this is around basically sending alert messages or coaching messages to patients. And it's showing some very interesting findings, very early days. What it's showing, some evidence around high patient and provider satisfaction. It's very easy to use, so therefore patients like it. And there's further funding and evaluation taking place right now in relation to that initiative. We also looked at MDAWN in BC, which is focusing on type 2 diabetes. It's in early stages of development and implementation. Again, focusing on text messaging and the use of web and mobile monitoring devices. I think what's really interesting about MDAWN is that it's looked very, very carefully and in some depth around its implementation and how it measures benefits and selecting patients as other projects and RPM projects across Canada and indeed internationally to try and get that right. It's developing quite a sophisticated research and benefits evaluation framework, and again focusing on where it recognizes there's some weakness in the existing data around patient and caregiver satisfaction, and it's worked quite effectively to secure key partnerships and involvement across providers and all actors across the health system in BC who need to be engaged in this. Third one is a virtual cardiac rehabilitation program, again in BC. It's focusing on ischemic heart disease and patients who are requiring a rehabilitation after a post-acute episode. Again, work is ongoing in terms of basically the equivalent of an RCT. It uses an online, quite smart interface on the web, which sort of mimics in a virtual way cardiac rehab programs. It's already showing some very promising findings in terms of really supporting patients to self-manage, improving their exercise capacity, reduction in risks of cardiovascular disease, as providing a very safe and effective environment by providing support for people to improve their exercise, their diet, use of cholesterol, and it's starting to show some benefits in terms of reduction of health human resources. The fourth one is my home health program in Alberta. This is focusing on seniors with CHF. It's using mobile monitoring devices, and it's trying to sort of bring together a much more complete picture using that technology of a patient's health and sort of various data points or information that might be collected in different places from regular practice visits. Using that data and synthesizing it and working with an interdisciplinary team, you can start getting into identifying risk factors and predicting the potential of adverse events in the management of that condition and being able to intervene proactively. So again, very exciting technology, but very exciting use of technology and a very exciting program. As I said, these programs, I'm sure everybody saw the launch of Apple's, I think, iOS 8 and some of the technology around health monitoring that they're starting to bring in. So these programs are starting to use, as I say, these very exciting developments in technology to support self-monitoring and the provision of information to patients with a range of conditions. This means, though, that the scope of RPM is starting to broaden to lower acuity patients. So if you remember the risk stratification framework, really focusing a lot of patients in that medium to low boxes. This is one example of where, unusually in healthcare, the lowering of cost of technology is actually happening, which means very exciting potential to expand the scope of RPM. And I say, really, starting to use very innovative technologies and patient-owned devices, and it's really the bringing together of that technology with clinical input involving patients in the design of specific programs or applications that holds enormous benefit. And as I say, as these more and more of these programs start to be developed, the evidence base for RPM in Canada will continue to grow. Moving forward and looking at how Canada and provinces can move to such a broader implementation of RPM, and in fact, really, RPM becomes central to how care is delivered and provided in Canada. Really found from the case studies, the interviews, the literature research, international evidence, 4 key interrelated factors that are absolutely critical and need to be considered by all actors in this space, both those involved in setting up and managing RPM programs, healthcare providers, health authorities, hospital systems, etc., vendors, and indeed patients, most importantly, to support the actual getting the design right from the outset, getting implementation right from the lens of trying to do this at scale, and really supporting the uptake of programs across Canada. And the first one is, it sounds self-explanatory, but we did find some variation, is engaging clinicians is absolutely critical in terms of their expertise and their buy-in to each of these programs. And that takes me back to the point of programs being able to actually demonstrate clinical benefits in terms of physiological outcomes and quality of care, etc. And similarly, clinician leadership is critical to ensure collaboration with other organizations and authorities to ensure the sustainability of RPM programs. So I know it sounds obvious, but it is actually absolutely critical in this space. Second area is patient recruitment, and I like to talk about sort of two ways of, as we say, identifying the right patients. So right patients mean being absolutely clear what cohort of patients we're targeting, going back to that risk stratification framework and aligning the technological solution with the acuity of the patient needs. And we've seen in the past from some programs where that wasn't got right or wasn't done as well as it could have been, which led to very sort of mixed outcomes in terms of cost effectiveness. So one is around sort of using sort of stratification tools to identify the right cohorts of patients. And even when you do that, it's around looking at your processes for individual recruitment of patients. There will be patients who are the right fit in terms of the cohort, but because of issues around their lifestyle or their environmental factors or the extent of caregiver support, may or may not be suitable for RPM solutions. And what's critical also here is the support that programs give to recruit and sustain patients in these programs through training, not just manuals, but through hands-on sort of support, so that patients are comfortable with the technology and are indeed changing their behaviors to support the self-management of their conditions. Third one is obviously, we've talked about this a lot so far, is around benefits measurement. And really, we just have to move beyond, looking at individual case studies and finding sort of variation in benefits and trying to, produce something compelling out of that. So there is a critical need to have greater standardization in terms of benefit and outcome measures that relate to cohorts of patients, acuity, etc. And really getting that right is critical, I think, to system-level buy-in, particularly from provincial payers, so that the evidence base here becomes much more compelling for RPM solutions. That is not just, as I say, looking at system utilization and the cost-effectiveness side, but also around, quality of care, physiological outcomes, access, caregiver burden, etc. And the fourth one, and Kathy mentioned this, is looking at RPMs through the lens of patient pathways rather than just applying the technology and getting that right. So RPM it can be a critical enabler to much more effective clinical care pathways and greater coordination of care, particularly between primary care and secondary care. And that means going from looking at the as-is in terms of a clinical pathway and working with clinicians, health authorities, and patients and providers, to then developing the 2B and the role of that technology in the 2B as that new pathway or model of care which supports greater care at home. So sort of the key messages coming out of that, I mean, our view would be a scalable RPM solution is one that engages clinicians, that has the right processes in place to recruit and indeed sustain and maintain patients, that measures benefits in a standardized way across all of the key criteria, and is then modeled against patient need and acuity so that you're never comparing apples with pears. A second one, and this came through as a message from our case studies and our emerging solutions, is the need to bring together learning from previous projects to sort of avoid, as I say, reinventing the wheel or people feeling they're starting from scratch on this. And other jurisdictions, for example, in the UK, have developed, leading to number 3, sort of websites and web portals that provide a lot of information on the evidence base, like our literature review, tools and templates around costing, guides around patient recruitment and retention. There's a lot of great information out there, and we just feel there's a need to bring that together in one place so that those involved in running or setting up RPM programs have access to it and don't get involved, waste time in unnecessary duplication. Local leadership, clinical and system-wide, is critical, along with consistent patient engagement. And there is a need as well for education. It sounds again obvious, but education around patients linked to sort of broader issues around how patients are supported to self-manage their conditions, to ensure appropriate design and sustainability. So ensuring that the design of the solution, the alignment of the technology to the acuity of the patient is got right. And the only way you can really get that right is through involving patients in that process. And then finally, benefits can only be realized if programs involve a critical mass. And again, that's absolutely important and sounds self-evident, but it is true. That mass that becomes convincing to both payers and to clinicians in terms of the benefits of RPM, and that moving away from just very small-scale studies that may not be that convincing when looking through that lens. In conclusion, it's a really positive story. RPM programs in Canada are most definitely moving and progressing from pilots to formalized solutions. Many large-scale programs are, not surprisingly, continue to target chronic conditions, i.e. patients who are the most frequent users of particularly acute services or most at risk of becoming the most frequent users. Very excitingly, smaller-scale programs are emerging that are leveraging the revolution that's taking place in information technology and smart technology and virtualization, of monitoring patients with less complex conditions. So again, an example of where cost of technology is actually being lowered in healthcare, which is unusual in itself. There are challenges, as we talked about, in just extrapolating the benefits from some of the leading programs we looked at, and that's around the sort of variations in design, the selection of patient cohorts, and the variation in terms of outcome measurement, and that means really further evaluation and program maturity are definitely required, and we would see that as ideally an ongoing process. Again, there's a need for different approaches to rationalizing scaling up programs for high and moderate risk patients, and I think our evaluation has touched on that in terms of the different approaches to the technological solutions being deployed and cohorts of patients being targeted. So it is not a case here of one size fits all. There is no doubt in our view that RPM is and has huge, even further potential to be a key enabler for transformation of the health system in Canada, and has huge potential to improve patients, to improve both outcomes and the patient experience through self-management and supporting patients to self-manage their condition, and promoting more care at home and avoiding unnecessary utilization of acute facilities. Continuing realizing the benefits will be critical, i.e. moving forward on our recommendations will be critical to formalizing RPM as a standardized model of care across Canada. That's it. Bobby, did you want to come in at this point?
Certainly. Thank you very much. And I did notice that some questions came in, so I'm going to start right away, and please feel free to jump in. So the first question is, this person comes from a decision support background, and they have been looking for how to apply our background in healthcare. So there are many devices that observe the patient health state. However, are there any programs with which you're familiar that automatically analyze the data and evaluate it or create alerts based on these different patient states?
I'll jump in to start, Bobby, and I'm sure that Ronan will add to that. The My Home Health program in Alberta was focused on gathering some biometric and current state health status information in residents and patients' homes, and the clinician group set, I would say, sort of a target level of status above or below which the primary care physician's office would be informed if there was variance in expected results. So many of the programs we looked at actually set a minimum or maximum criteria in terms of the biological indicators in order to appropriately engage a physician if there were alerts to invite the patient in for a consultation or potentially a phone call from a nurse monitoring system. That's one example. Ronan, you might have some others.
There are, but I'd sort of make the general point. I think it's an excellent question, and I think it's actually key to where this is going. I think I could be slightly incorrect around this, but I think MDAWN is certainly moving into this territory in terms of the alerts, and as we see the exploitation of a smartphone, tablet, and other technologies, and we know Apple are launching their watch. I think this is where this technology is going to go, and I think it's going to focus at that medium cohort, and with the technological devices will improve both in terms of their sophistication and their simplicity to allow that routine monitoring of key biosigns depending on the nature of the condition, linked to clinical monitoring, and where variation in terms of those biosigns will trigger, what's called triaged alerts, and an intervention can take place to avoid, i.e., if possible, you stabilize that exacerbation or variation in condition at home and avoid acute admissions. But I think it's a great question, and I think it's exactly where this technology will go and is going.
Thank you very much. We'll move to the next question, and just a reminder to all the participants that the question line is still open, so please feel free to type in additional questions. This next one, the benefits that you have presented seem very compelling, but why hasn't RPM grown faster?
One of the reasons is related to the inconsistent measurement of benefits. So as vendors, clinicians, patients consider the adoption or use of remote patient monitoring, there's an expectation that the benefit of the investment or the use of the technology as part of a care plan will show specific outcomes or benefits. And during our presentation, we mentioned some of the variability of data that truly demonstrates consistently the benefits from different technologies for different patient populations. So that is one of the factors that's influenced adoption, and certainly one of the recommendations from the report is that remote patient monitoring programs should be considering a consistent way of measuring some of the outcomes and benefits to further increase the interest and the recognition of the benefits of remote patient monitoring solutions.
I agree with all of that, Kathy. I think just to give an example of what's bedeviling this, the whole system demonstrator program in the UK, which was, I think, to date the largest, if you like, equivalent of a random controlled trial using this technology. It was first established in 2006 in the Department of Health, and I actually was involved in setting it up. It didn't publish its main findings until 2012. Now, when we're talking about solutions that involve technology, one of the obvious observations when the findings came out, and some of those findings were positive, well, isn't the technology becoming a bit outdated here? So I think going forward, we have to find smarter ways of both real-time measuring the benefits, rather than relying on entirely evaluations that have quite long lag times to demonstrate the benefits. So we've got an area here where the technology is going to become more and more innovative and more disruptive, and rightly so. Governments should be encouraging vendors to do that. But that means, and I think there's some potential here with some of these emerging solutions, we need to get much smarter, and vendors can help with this, around real-time monitoring of the benefits, to sort of say, look, week on week, month on month, here are the outcomes of this solution, aligned to ideally agreement across provinces around a standardized benefits measurement framework as discussed earlier.
Thank you very much, both of you. And actually, related to your comments, Ronan, there's another question. What are your recommendations in terms of developing standardized benefit indicators? And if COACH, for example, were to host a best practices special interest group, where should this group start? Is there a set of starting measures that would be worthy as a good starting point?
Well, I could be very arrogant and say ours, in terms of what we developed, but actually we did obviously, as part of our work here, consider this, and actually CHI's benefits framework we thought was a good starting point. And actually, when you think about it, you would automatically sort of focus on domains around quality, around access and productivity. So a starting point is confirming those as sort of the core domains, and then focusing on what are the critical indicators that A, we need to measure, B, that can be measured pragmatically, and how do we then develop, once we sort of agree what it is we want to measure, then have a process around how we want to measure it. And as I say, that there's the balance here between the need to do retrospective work, but also have a process in place that allows, if you like, ongoing real-time benefits measurement, and putting in place tools and processes that enables that to happen. But without question, this needs to be done, and ideally it would be done in a way not just by individual provinces, but across Canada, so we get some national consistency.
That's great. Thank you so much. And another question came in. In your experience so far, how have RPM programs changed the roles of home caregivers and visiting nursing staff?
Did you want me to take that, Kathy?
Sure, Ronan, yeah, go ahead.
Yeah, sure, I'll confess to a slight past life on this. I was involved in, back in EY UK, with supporting quite large-scale rollouts of RPM solutions in relation to telehealth, and our approach was, a starting point was actually redesigning the care pathways, which involve CHF, COPD, and type 2 diabetes, and also fundamentally the model of care. So we were looking at absolutely how the nature of roles of each of the actors in the health system changed. So for example, when looking at home visits and nursing, one is, if I look just at nurses, they obviously have a cost, and you want to use your limited nursing resource to patients in most effect. So the change in that role was one around becoming involved in the triaging and observation of alerts and responding to that. So nurses having devices that receives the alert messages and intervening perhaps initially remotely, or then depending on the nature of the alert actually intervening and visiting the patient's house. But what it did do was it took out some visits that were just routine in terms of observing the patient, to that being done remotely through use of the technology, and targeting nurses' visits where most appropriate in terms of acuity or risk to patient care. So it has significant implications around those roles and how nurses and other professionals such as physiotherapists and OTs are involved in supporting care at home. But I believe quite passionately that that's the lens one must take when looking at this solution, is looking at how the pathways, the clinical pathways, need to be redesigned, and then secondly, how the model of care is then developed with RPM as enabler that is sustainable and effective for patients and does deliver the system benefits that the health system is trying to achieve.
That's great. Thank you very much for all your insight. And I apologize, I didn't do the talking, but my voice seems to be going. So thank you again to the presenters. And we have one last question, and I think I will be answering this one myself. It's when will you be making the study available online? And I can say that it will be available later today on the Infoway website on our resource page. And as well, when you receive the evaluation survey for this webinar, we will include a link to the materials as well. Also, a copy of this webinar will be available in about a week if you're interested in sharing with any of your colleagues. So once again, thank you to everyone who participated. Thank you to the Ernst Young team for such a great study. And I hope that everyone will join us next time for our webinar series.